Hi everybody, just waiting for someone to join up. We'll just wait for a few people to join. Welcome everybody. Hi there Trish, nice to see you on. Welcome everybody. Sorry I missed the other night. I was pretty busy and had a patient who was needed me urgently, so I had to cancel. I apologize for any of you who were going to, hi Sarah, for anyone who was going to be there and I sort of let you down. I'm sorry about that. Good evening, Elaine. How you doing? We'll just wait for a few minutes and let anyone who's going to sign up, and then we'll get ourselves going. Some people sent me some questions, so we'll probably start with those. And good. Well, why don't we actually get started on those sorts of on what we've got? I got a few questions. The first one that I got asked was, do you do liposuction on the Mons pubis area with a tummy tuck, or can you do it as a standalone procedure? The answer to that is yes to both. Certainly you can do, I pretty much routinely do liposuction to the Mons pubis area if it's required. In a lot of massive weight loss patients it's required, but it's often not required in patients who are having abdominoplasties for just after pregnancy, etc. But it's something I do get asked a bit. I actually get asked occasionally to even do some fat grafting to the area in ladies who've lost a lot of weight, who have deflated there as well because it's lost so much weight. Over the years, I've certainly individually done liposuction to the Mons region in patients who found that they were too large in that area. Yes, Sarah, where my practice is, Sarah's just asked where I'm located. My practice is, I've got two practices really. I'm on the Gold Coast, but I've also got a branch practice in Ballina that I've had for 20 years pretty much. I've been going to the Ballina Lismore area since I started. My principal practice is next to the Fair Road Markets on the Gold Coast. So it's a nice building there, a nice place to be. So it's very good. And one of the other questions, please post any questions that you may have if you want me to answer them. I'll be happy to chat. The next question that I had was, can you explain the Medicare rules, what the Medicare rules are now with tummy tuck and the Medicare item numbers, and which health funds do I think are best? So from the point of view of them, as many of you will know, there's been a very interesting change back in, it was about 2 years ago, I think, to the rules with regards to tummy tuck. It kind of made life a bit difficult at the time. It's kind of settled in there now. Basically, the rules are now, you need to have a weight loss greater than 5 BMI points. You need to have a risk of skin breakdown that has been resistant to treatment, and it needs to interfere with your activities of daily life. And the weight loss needs to be stable. So we used to be able to do tummy tucks pretty much post-pregnancy, patients with divarication, and that got taken away. There's a lot of work going on to try to get that back, because in fact, there's a lot of data to show that abdominoplasty, where particularly the tightening of the muscle, can cause an improvement in things like back pain, also in urinary incontinence and things like that. So obviously Medicare is changing as the time goes by, tightening all those the rules. So I hope that answered that question. The next, if anyone's got any other questions, let us know. Oh, Sarah, congratulations on the 68 kilos. So, well, let's talk a little bit about massive weight loss, or dealing with things like post-massive weight loss, because some of the other questions I've been sent have to do with that. I think the most important thing to think about in the reconstruction of patients who've lost a lot of weight is to understand it's a journey. It's not a one-stop thing. I think it's a real relationship you need to develop with your surgeon, and you need to talk to them about a reconstructive program. I think it's a mistake to think that you're going to do everything in one operation, and that the first thing I usually say to somebody when they present to me in this situation is I say, okay, let's make a list of the things that bother you and let's prioritize them. Because if we've got issues with breast, tummy, buttocks, legs, arms, face, you can't do all that at once safely, and it would be silly to try to do that safely. So what we want to do then is put together a program that's going to work together, and they're all going to be able to meld together and make the operations such that the post-operative care will be appropriate. And generally, one of the questions I got asked, I got sent was that, what do you do with, for example, revisions? What I actually do from the point of view of massive weight loss patients is I plan that in our reconstructive program. Essentially, patients who we're dealing with from after massive weight loss have got a 100% revision rate, pretty much 100% chance of having some minor complication here or there. So what the thing to do, for example, would be, let's say the main priorities are things like breasts and tummy, then and then after that, say arms and legs. Then what I would usually do is say, okay, well, let's do your breast and tummy, get the sort of the major work done, and when we come back to do your arms and legs, if there's little touch-ups that need to be done on the breasts or the tummy, we can do them at that time. And so I normally build that into the reconstructive program. Very, very much a sensible thing to do. So Brianna's asked a live question there. Lost 50 kilos, train every day at the gym, weights, good posture, but you got back pain. Would it be possible to have a tummy tuck may help? Exactly what I was saying just before, Brianna. The fact is that often what's happened is you've got a divarication of the rectus, which means that the abdominal muscles then don't work to their most efficiency. So it's a bit like trying to pull a car along with a rope. And if you pull the car with the rope with another car, then it's going to just pull very easily. However, if the rope is now a bungee cord and it just keeps giving, then it's much less efficient and it doesn't work. So similarly, that's what happens in the tummy, is that the muscles are sitting like this and they're pulling, but as they're pulling, the bit in the middle kind of pulls apart. So if you can repair that together so that there's that core strength, then that makes things work a whole lot better. And by that efficiency can really help from the point of view of back pain, but it also can help from the point of view of things like urinary incontinence as well in patients who have that problem. Seems a little bit sort of counterintuitive, doesn't it? That you get there and tighten this muscle in your tummy up, and it actually fixes urinary incontinence. But it's got to do with the fact that your pelvic musculature has to pull on something, and if there's nothing to pull in the abdomen, then it doesn't work as well. So there's a lot of really good data to show that that's the case, and that's why a lot of us were very disappointed when, without any evidence, the Medicare decided that that wasn't going to be allowed anymore. It was primarily a cost-saving measure. Sarah's just said her arms are first. That's a reasonable thing, Sarah. It's really a matter of whether you what your priorities are and how that's going to work as part of that reconstructive program. Crystal, yeah, I certainly do body lifts. Once again, it's a matter of working out what patients require. So sometimes doing a circumferential body lift where you'll do the abdomen and the buttock and the back at the same time works really well in some patients. In others, it kind of doesn't really fit with the reconstructive program that you're trying to do. So sometimes what we may do is, because it becomes quite uncomfortable to do front and back, so what I may often do would be to do an abdominoplasty in the breasts together so that you can lie on your back, and then we would do the back secondarily with some touch-up procedures and things. So it really just depends upon exactly how it's going to work for you. And it's very, very individualized. As people lose weight, they lose it in different patterns, and they're left with different deformities that we need to deal with. So that's the key, is exactly that, is to individualize it, like everything we do. I mean, we individualize facelifts. I did a facelift today, had a really busy day today, and the facelift I did today is very different to what I would often do for various reasons, just because that patient required a different operation. And that's the beauty of plastic surgery. It's what I love about it, is our ability to see a problem and then deal with the problem in a logical, sensible way. Yeah. Yeah, so Brandon, exactly. The fact that you don't have any back pain when you weight training, if you wear a support belt, that's good. So Trish just passed one on that. Is there still a rebate if my youngest child is 7? I think you're talking about breastosis. That one at the moment, I think, is still in place as far as I'm aware. So uplifts, if you've got a younger child that's younger than 7 for breastosis. Yeah, but that's a sort of thing that we can easily answer. Oh, Charlie's asking, why doesn't Medicare allow 2 procedures at once? Oh, Charlie, we could talk all of that all day about the logic of Medicare. Look, in the end, the way to think about Medicare is that there is a pool of money, and they decide how that's going to be cut up. Over the years, plastic surgery has been a pretty easy one for them to try to cut things out of. Unfortunately, my wife has just texted me and told me that for a child under 7, but nowadays we need more documentation, by the way. So Medicare doesn't allow 2 procedures. Well, it does allow 2 procedures at once, but what it does is, after the first procedure, it halves your rebate, and after that, it takes it down to, I think, 25% or 10%, and then it stops paying at all. So that's what Medicare does, and it does it as a cost-saving measure. Recovery time for tummy tuck and arms. The recovery time for tummy tuck and arms, essentially, what I would do usually would be have a patient. We do a tummy tucks normally in hospital about 2 to 3 days. So let's talk about tummy tucks. When I do an abdominoplasty, what we will do is pop you off to sleep, put a catheter in the bladder, and then make the appropriate incisions. Now, there are different types of abdominoplasty. We could do everything from, a patient who's just got divarication, so muscles pulled apart, but not too much of a skin problem. We can do just a modified abdominoplasty. We would just make the cut at the bottom, come up underneath, and then just tighten together the muscles, and just take a little bit of skin out and float the belly button. Then there's a kind of classical abdominoplasty, cutting out the lower part, moving the belly button back up. And then there's the fleur-de-lis abdominoplasty, where we cut out in a big fleur-de-lis type shape, which leaves a vertical scar as well. So anyway, make the appropriate incisions, tighten all the muscle together, and then at the end, one of the key things I think that I do that works really well is, firstly, put in little pain pumps that run up inside the muscle. That's been an absolute life changer for me, and in that what it does is it makes the patient so incredibly comfortable. So, for example, I do a couple of tummy tucks at least every week, and I did one yesterday. I saw the lady this morning, and she literally has had one pain-killing pill over 24 hours. So she's done really well, and that's pretty standard because the local anesthetic just takes away a lot of the pain. And then also just reattach everything down as you come out so that you don't get fluid collections and things. So that means largely just from a a practical point of view, most patients are in the hospital, say 3 days. I'll often do them on a Monday afternoon, out by Thursday. And then really it's a matter of what your job is as to when you can go back to work and do things. Most people have a couple of weeks off if they're in a sedentary job. From the point of view of being full on back at the gym, smashing out yoga and a gym session is probably up to 3 months, but you can work up to that. From the point of view of the arms are probably secondary to that. It's probably more the tummy that's the slower thing to recover. From the point of view of the arms, the big thing is the scar, and it does take many months, 3, 6, even 12 months for the scars to settle down, and that's all about scar placement and scar management and how individual people scar. So I hope that answered the question. Elaine, you're 13 weeks after FDLA. I'm trying to think of what that stands for. Sometimes the letters used by people are all different. So I'll have to think about that. If it was fleur-de-lis, sorry, fleur-de-lis abdominoplasty, got it. If there's no fluid there and you've still got some swelling, then I would probably just keep wearing your garment, really. The big thing to be sure of after a fleur-de-lis or after any abdominoplasty, if you have persistent swelling, is that there isn't a collection. And if there isn't a collection, then at this point, there's probably nothing much else to do. Hi, Sarah. Yeah, no problems. Sarah, I won't have your contact details, but the easiest thing to do is just punch in Dr. Layt, L-A-Y-T, and give us a yell. But I'll make a note, and via Trish, we'll see if we can get your contact details and give you a call. Otherwise, just call the practice tomorrow. So I'll just make a note there for you, Sarah. No problems at all. Cool. Yeah. Thanks, Elaine. I realize now what I was. It was a fleur-de-lis. Got it. Other questions I've got here. So this is my first time for all this, so I hope I'm doing okay. It's kind of pretty full on having all these things happening at once. There's a question here about. I'm told I have to have a corset abdominoplasty, but worried about having a scar up the middle of the belly. Is there another option? And should I have a second consult, see if there are any other ways? Look, that's a really common thing for us to talk about. And often I'm chatting to patients about the pros and cons of scar versus shape. And that's not only in abdominoplasty, that's also most commonly, I suppose, in my practice, really to do with uplifts and implants, so augmentation mastopexy. And the reason for that is that patients don't want to have scars on their breasts or scars up the middle of their abdomen. But the thing is that what I say to patients is that scars get better as time goes on, but shape gets worse generally. So there's no use having a great big set of big saggy boobs. They're not going to get any better. Similarly, there's no use having a tummy that doesn't have a nice waist to it just to get away without a vertical scar. So I think that that's really a discussion you need to have. From the point of your second opinion, look, I think if you're ever concerned about anything, it's worthwhile getting a second opinion. And, I think that from another specialist plastic surgeon and, weigh up the different pros and cons for the procedure. So Elaine just said it's new swelling. Elaine, if it's new swelling, it needs to be reassessed again, maybe another ultrasound. You need to see your surgeon or whoever's covering your surgeon's practice. All of us would, if we're going overseas, as it seems your surgeon may be, would have someone cover the practice. That's a pretty standard professional procedure. So I would contact your surgeon's practice, say you've got some other concerns, who's covering, and get them to have a look at you. I think if it is a collection, it may need to be drained. That's very possible. Hey, thanks Trish, thanks Brianna. I'm trying my hardest. Hey, Tina's there. Hi Tina, how are you doing? It's great to see you there. That's great, Steph. The scars, they get better. So look, what I would say to most people is, you know, you have to kind of embrace the scars to get the nice shape. And a lot of it's all about scar placement as well in many cases. So yeah, Elaine, garments 3 months usually. Yeah, thanks for your question there. Okay, so I've got a couple of other questions here. Oh yeah, talking about breasts, and that's is there a size to go that avoids rippling, and what's the percentage cases that rippling occurs? Let's talk about rippling and breast augmentation. That's always interesting. Essentially, unless you get a solid piece of silicone and place it in your breast, there is the potential for rippling in every patient. Now, everything we do with breast augmentation is a balancing act. It's all about pros and cons, risks and benefits. Ideally, what we want is to have enough cover over an implant that any of the little irregularities you'll get as an implant moves and folds will be covered by that little bit of fat or breast tissue. Now, there are patients who that's really not possible in because they're so thin. So what we will sometimes do in these situations is we can actually, for example, try to cover it up with a little bit of fat grafting if the patient has some fat somewhere else. So we have lots of patients who have a very little breast tissue and very little fat in their chest, but they might have some fat on their inner thighs or outer thighs, and you can do a composite breast augmentation, which is a very good procedure, works very, very well in those patients. So the whole concept is that what we need to try to do is get the most coverage we can over the implant. So at the top of the breast, what we can do is we can put it in underneath the muscle, and that will enable us to get more coverage at the top. So rippling is very uncommon at the top in a subpectoral or a subpectoral implant. The other thing to do is to try to use an implant that has a thicker jelly. So if we look at the various implant brands around the place, each of them will tend to have a jelly that's sort of a level 1, level 2, or level 3 thickness to the jelly. So in a patient who we will use a level 3 sort of thickness jelly if we want to either work hard on the breast, so push it hard to change its shape. So if someone's got a lot of tightness at the bottom, or they have a tuberous breast deformity or some problem like that. And in the other situation that we would want to use that style of implant is in a patient who has a high risk of rippling. So not a lot of good tissue quality, not a lot of coverage over the tissues. So I think rippling in some patients is inevitable, and I tell them that you will have some rippling just because you're so thin. So if I've got someone who's, BMI's 16 or 17, it's very unlikely they're not going to get some degree of rippling just on the outside of their breast there. So I hope that answers the question. Percentage of cases is really hard to sort of pull a percentage out. But I suppose suffice to say, the thinner the patient is, the more likely it is. Sarah, I've just written your number down, and I will get my staff to call you tomorrow. Good luck, Elaine. I hope that's helped. I would really just give your surgeon a call if you're concerned about anything. I'll follow on with a couple of other questions I've got. If anyone's got any other things, please put them up. I kind of now know what a radio disc jockey feels like, controlling the questions coming in and doing things. You're right, Trish. It's quite a lot of fun. I've got a question here about had a consultation on the Gold Coast for breast augmentation, and the doctor wants to put an internal bra in. He said it dissolves in about a year, but what keeps my boobs up after that? Okay, this concept of an internal bra, essentially it's just, there are various supporting structures that we can put in to help support implants. Now, I've been on the pilots for a few of these over the years, done some of the research for them. There are ones that are permanent, ones that are less permanent. A lot of them are also ones that we use when we do breast reconstruction. Some of them are what we call dermal matrices. So they're actually from pigs or humans or various other, or sheep. And they're basically the collagen out of those various animals, including humans, and all of the antigens are taken out of them. They're very complex the way it's all treated. And then you can put that in as a supporting structure. Your body then kind of takes that over a period of time. There are other ones that are actually permanent meshes. They can be very good because they're permanent, but the negatives can be if there are any issues with them, they are permanent as well. The other things that, so the ones that tend to dissolve over a year or so, they leave behind some scarring, which will then help to support your breast. And really they're a helper. They're not really a replacement. But certainly in situations where you have people who have very poor tissues, it's not an unreasonable approach. But it isn't without, it certainly makes the operation significantly more difficult, time consuming, and some of those various matrices and meshes can be quite expensive. So some of them, they can be anything from $800 to $10,000 a sheet. So they can certainly be very expensive. There's a new one that's probably going to be coming out. It's in the US, will be coming out in Australia probably, I think, maybe next year. They've been talking to me about doing some things with it, and it's called Galaflex. My friends in the US tell me it's pretty fantastic. So I can't wait to get my hands on that. That will be very good. Always nice to be trying new things. Let's see what we've got. We've got Ainsley's just says she's post 2 kids, youngest 2 kids. She's 10 centimeter separation. Yeah, that's pretty bad. So it'd be pretty wild. That should be obvious to you when you sit up. I would expect if you do a bit of a sit up, you get like a little keel effect in the middle. There's Ainsley doing breasts and tummy at the same time as my life. Pretty much abdominoplasty and uplift with implants is pretty much what I do on a daily basis. The sort of mummy makeover type thing. So you sound like you'd be a great candidate for that. I mean, the best thing to do at that point is to really make sure that you've got your yourself at a stable weight, and you know, if you live near the coast, I'll be happy to see you. It's a great operation. Trish has posted a question there. Honest question: what technique do you use for breast lift? Yep. That doesn't make much sense. We're doing amazing things. So this is true. Yeah, we can do amazing things, but I'm not sure if you were with us earlier, but really the scars get better and shape gets worse. Now let's talk about scarring and breast uplifts. Essentially, there are some patients who can get away with just a little periareolar scar. I generally will still put the implant through a little cut underneath the breast, and there's a whole lot of reasons for that we can talk about, but a lot of them relate to what's called a 14-point plan, and that's also about stability of the fold. So sometimes we will put a cut in underneath, put the implant in, and then go and do a little periareolar mastopexy. That really only is going to get you a centimeter or two, and so only in the very borderline cases will that work. Most of the time you need to scar around, down, and underneath. Just think about it logically. The logic is that what are we trying to achieve with an uplift with an implant? What we're usually trying to achieve is to fill the top up more, hence the implant. We're trying to decrease the horizontal and vertical distances and move the nipple. Now, you can move the nipple a little bit just by making a cut around it, but you can't change that distance horizontally. And so what you'll often get in that situation is a breast that's a bit flat, and where the breast tends to hang over the implant and not look that pretty. Now, all of us I would rather do things without a scar if I can, but similarly, we want a pretty breast, and the scar's going to keep getting better as time goes on, and the shape will get worse. So really what you need to do, whoever asked Trish that question, is to talk to your surgeon about what is the best option for you. And you'll always get someone, I'll be honest with you, you'll always find someone who will do something as minimal scarring if you push them hard enough. But the question is, you'll probably end up unhappy if it's not the right thing to do. And so I would get some advice from somebody who will just be honest with you and tell you this is the result you can get. Someone who's done a lot of them, can show you the photos and the possibilities that they think they can get with you. We use a vector imaging system, which is a 3D imaging system as well, which can really help do that. I can't do that the vector down in Ballina. If any of you are from Ballina, I can see you there, but we would need to get you up to the coast because it's a great big machine that we need to deal with on the coast. Ainsley, my pleasure. There's no such thing, Brianna, as an invisible arm lift. I do get asked about just making cuts just up in the armpit here to try and pull things up. There's a small number of cases that will work in. Just think logically about it. The reality is that if that's the circumference of your arm and you've got, this big bit of stuff hanging down here, nothing you do up here is really going to decrease the distance around. You have to do something here. And, that's why it's one of those operations that I really wish we could do something else with. I wish there was some non-surgical skin tightening that works well enough to treat that. We do have some that works a bit, but not enough in most of those cases. Yeah. Tracy went from a G cup to a saggy D after bypass. And need a lower body lift and a breast reduction and a BA at a later date. Yep. And cool. So look, what I would say to you, Tracy, is it all sounds pretty logical. Most patients who've lost a lot of weight, it's not wise to do an uplift and an implant at the same time. Generally, what you want to do is create a nice stable base and then build on that. Now, the reason for that is that many of you in this forum are probably have lost a lot of weight. And what you're going to find is that your fold position is often quite low and it often moves a lot. So you really need to make sure you fix that down. And the problem that you can get into if you try and put an implant in at the same time is that you can get it so that the T-junction at the bottom will break down if you cut it in both directions, internally. And so, uplift with implants is kind of one of my babies, I suppose. And so generally what you want to do in that situation is get a stable base and do the implant secondarily. Now, as we talked about earlier, with one of the real key things with dealing with patients who've lost a lot of weight is to get a relationship so that you can talk about the reconstructive program. It is not a one, let's do one operation and everything's fixed and et cetera, et cetera. It's almost inevitable that there will be some recurrence of a bit of laxity, a little thing you want to revise. Build all of that into the reconstructive program. Just have an honest discussion and say, this is what's going to happen. These are the likely problems we're going to have. We're going to get through it together. This is a relationship. We just need to work on it together. Like any journey, there'll be some bumps, and you just got to ride those bumps together. So Tracy, yeah, look, I don't think the waiting list is too long for a consultation. I'm not sure. I've got 26 staff, so they kind of tend to run my life. But I'd be only too happy to see you. And if you just call the practice, you can just go on to the Layt clinic, and my staff will be only too happy to help. Most of the time, they're really pleasant, except when I'm grumpy. Jean asked me, can a reverse abdominal bias be done at the same time as a breast lift? You can. Need to be a little careful with things. I did exactly that just probably a month ago. So sometimes what you'll find is if you've had a tummy tuck and it's gone from below, sometimes you can find you get a bit of a recurrence at the top. And if you do that, then what you can do is use the scar for the breast lift, come down and lift everything upwards. Gina, I'm not quite sure about the kind of idea from the point of view of two procedures. It's probably considered two procedures from the point of view of things like Medicare billing and stuff, and that there would be a wedge item number or something for the abdominoplasty. There'd be a lift or reduction item number if that was appropriate. Most of the time, depending upon insured, uninsured, how all that works. And it can be very complicated, particularly in situations with massive weight loss patients. It's kind of one of the reasons I got 26 staff, I suppose, is they have to deal with all that stuff. But once again, my staff will be happy to talk to you about that and give you some ideas. And I'm only too happy to see you and have a chat. Kelly, rapid recovery. I presume you're talking about maybe breast augmentation. The reality is that 93%, I think it is, of our patients who have breast augmentations are right to go to lunch the next day. We're right next to the Fair Road Markets, which is a very pleasant place, in the main practice on the Gold Coast. And so that's all about rapid recovery from breast augmentation is all about technique. It's all about, and I'm not sure you're aware, but I run a whole lot of teaching academies and stuff on breast augmentation, and that's part of the thing we do. We run a fellowship program and all sorts of stuff like that. And it's one of the things I'll lecture on at meetings. The key to getting a rapid recovery in a breast augmentation is stopping the pain before it starts. So those of you who've been in this discussion since the start will understand when I talked about putting in pain pumps and things in the abdominoplasty. I'm very proactive with respect to the use of local anesthetic when it comes to operative procedures. So when it comes to a breast augmentation, my anaesthetist puts in blocks in between the ribs once you're asleep before we start the operation. I put some local anesthetic in the incision that I'm going to make, which means that during the operation, you pretty much feel no pain, and therefore the anaesthetist doesn't need to use much narcotic. During the operation, also very careful to keep no bleeding at all, and also not to go banging on ribs or doing anything that's sort of brutal. Try and be as gentle as you can be in a surgical procedure. What that then means is that if you're not using drains, you're not binding people up, you're just putting a bra on them afterwards. Most patients might take a couple of Panadol. It really can be quite amazing how little pain you can get. And because when you look at anesthesia, there's multiple things to it. The anaesthetist keeps you asleep, gives you some stuff so that you don't remember anything. If need be, for certain operations, will keep you paralyzed. Don't need that in an augmentation, but may need that in a tummy tuck, for example, and will provide pain relief. Now, the pain relief is usually some form of narcotic, and that's why people can get sick after surgery. So if you can reduce the amount of narcotic you need to use during the surgery or after the surgery, then you can get a very rapid recovery. So I hope that every procedure, not just breast augmentation, I'm always trying to get patients better as quick as possible. Facelift with hamburger with a lot facelift and with extra cheese. I do a lot of professional people on boards and doctors, lawyers, etc. And I tell them all, we can get you back to work in 3 weeks. Social downtime is 3 weeks for no matter what you do with a facelift. You can definitely be back in 3 weeks, sometimes back in 2. All right, sort of moving on. Steph, lost all the weight, you're steady, but you've still got some fat in your hip area. Sure, no problems. Steph, I mean, that's an individual thing we'd need to assess. I mean, certainly you can do some liposuction if there's a localized area. And really, liposuction is not about weight loss. It's about reshaping an area to match other areas. Now, it may be that your surgeon feels that other areas need to lose some weight as well, and that you would need to, you could do the liposuction once you're at that level, rather than doing it at this point. Without an assessment, it would be hard to say, but certainly liposuction, great areas for liposuction are thighs, in and out of thighs, but it also depends on skin quality. And with liposuction, what you're really doing is sort of creating a honeycomb and then compressing it with the garment and trying to get it to scar underneath, get the skin to tighten over it. So the problem is with patients who've lost a lot of weight is really the skin quality. And most of you would know that, and it's the issue rather than often the fat. So just getting rid of fat's not going to necessarily help if you also need something done with the skin. So potentially what your surgeon's doing is saying, look, we're going to have to do some other incisions to cut things out. We may need to reduce, do a thigh reduction or something like that. Let's try and get everything to the weight we want it to be before we start. I'm not sure. Kaylee, thank you very much. Nice of you to be here. Genevieve, is there a better season to have a large hernia repair? Yeah, look, reality is if you need a tummy tuck, you can do it summer or winter. You do need to wear a garment, so probably the cooler months are a little bit better. So you certainly can, liposuction similarly. So I do more liposuction and other body contouring stuff during winter than I do during summer. But that's not to say you wouldn't and you don't. Probably I don't do much liposuction during summer, but I certainly do a reasonable amount of body contouring of other types like tummy tucks and things. They're a year-round thing. But things like, for example, I tend to try and talk people out of having their kids' ears put back during summer. There's no way a kid's going to keep a bandage on their head for a week when all their friends are going swimming. So that's best done during the winter school holidays. And that's an operation I love doing during the winter school holidays. It's good. Cool. Yeah, I'm with you, Steph. It'd be lovely to just do it in one, but it does take a lot. And it really is just a matter of trying to get the best result and, having some trust that and understanding between yourself and your surgeon that you're both on the same plan, to try and get where you want to be. Everyone's just trying to do it. Tracy, is it due to skin integrity after I have a breast reduction to a B cup? Will there be any issues with implants regarding size at a later date? Do you do fat transfer to create some fullness with a breast reduction? How long after breast reduction can you have a BA? Sorry, this not stupid at all. Look, bottom line is if you're reducing things and getting up, I normally wait about 3 months. Generally speaking, if I'm doing a breast reduction, what I try and do is rotate tissue or a lift. I try and rotate tissue from the lower pole to the upper pole. So there are various ways you can leave the nipple attached. The way I tend to leave the nipple attached, and I did this today, I did 1 kilo each side breast reduction this morning, is leave the nipple attached in what we call superomedial. So by leaving the nipple attached up here rather than at the bottom like I was taught 30 years ago, when you rotate it up, it actually tends to fill the upper part. Often doesn't stay there, but it certainly is a lot better than I think having it coming from below, where you tend to get too much fullness at the lower pole, which then tends to increase and come down as time goes on. There's Michaela. No, there's not really a weight limit for a breast augment. You're 6'1". We have to deal with BMI, but you have to be sensible about BMI. I am never at my ideal BMI, and I never have been. I was playing football for the state, AFL for the state many years ago, and was still above my proper BMI because I'm a pretty strong guy. And I'm with you that muscle can play a role. So I agree with you completely from that point of view. It's probably a balance between those things. I mean, if you're appropriate for a breast augmentation, you're appropriate for a breast augmentation. BMI is probably not that important. It's really a matter of the whole picture, and that's what needs to be looked at. Yeah. Kelly, from the point of view of weightlifting at the gym after a breast augmentation, the discussion then needs to really largely be about pre or subpectoral. Now, I've got some patients who literally world level bodybuilders, serious bodybuilders. Now that's very different to somebody who is, a sort of gym junkie fit type of person. And the bodybuilders, we tend to need to think about using a teardrop shaped implant in front of the muscle. And they're going to need to accept the fact that they will see the edge of that implant at the top. Because if you put them under the muscle, and those girls who've got bigger pecs than I have, and there are quite a few of them, then it doesn't work very well. If you are someone who likes to do a lot of work in the gym and you are happy to modify your behavior a little bit, so instead of doing lots of flies and bench press and wider-handed push-ups, and maybe change it to close grip push-ups so that you're using more tricep than bicep than pec, then we will be able to still go under the muscle. I try to get you to avoid pec exercises for 3 months, but other gym stuff's fine. Most of my augment patients will be back on exercise bikes within a week. They're walking straight afterwards. Within 2 weeks, could be considered, doing some leg stuff. Within a month to 6 weeks, they can be doing probably 6 weeks, doing significant back and arm things. But I really like to try not to do too much chest stuff. If you have a shaped implant, you really need to be careful about doing chest stuff for 3 months plus, because you can get a rotational effect. And that's one of the pros and cons we need to have a chat about, depending upon what implant we're going to use. So a lot of the times, the problem that we get with some of the information on the internet is it doesn't take into account the fact that I get a lot of patients coming in saying, I want this implant because I saw it and I like the shape of it. The most important thing from the point of view of the shape of your outcome is actually where you start. So if you start in a certain situation with a breast augmentation, then it will tend to drive what we need to do. So people were talking about, the largest size. There was another question about the ideal size of implants and things. The reality is, think about it like this. It's like building a house. If any of you are from the Gold Coast, there's Hedges Avenue, right? So right on the beach, everything's about tight little blocks of land. You can't take the house that you build on Hedges Avenue and put it out in the countryside. It looks ridiculous. It's a 4-story block like this. But if you try and build the house that you're building, out on your 10-acre block on Hedges Avenue, then that's not going to work either, because you're going to be taking up 10 other people's blocks of land. It's the same. If I've got a girl who is, 5 foot tall and thin across the chest, she may only be able to have an implant that's 10.5 or 11 centimeters wide. Whereas if we've got someone who's 6'1" with a wide chest, she might be able to have an implant that's 14 centimeters wide. Similarly, vertically, I'm going to have patients who have really long chests or really short chests, and we're going to use a different basement on those patients. So it may be that we need to use a shaped implant because the base of the breast needs to be 14 by 12. So I try to use a round-based implant if we can, because it avoids the risk of rotation. But if that's not going to get a good result in a given person, we have to accept that risk of rotation and try and modify it in order to get the best result. And so that's why it's not really, there's a lot more to doing breast augmentation than just popping implants in. And that's why, you need to go to someone who knows what they're talking about. Then the volume becomes how many floors we put on it. So if you're building your house, you don't say to your architect, I want a 1,247 square meter house. What you say is, I want 4 bedrooms, 3 bathrooms, and I want a study. And from your block of land in the basement, he can then work out, or she can work out what volume you need in your house and how many floors you may need. So I hope that kind of answers that question, which went a little bit off to one side. Cool. No problem. Thank you for thanking me, everybody. That's really good. I appreciate it. Trish posted, can I stuff up my BR if I do weights too soon? Because I think that's what I've done. Yeah, you can. You can certainly, if you've you can certainly rotate implants and do all sorts of things if you get back into things too early. But I would talk to your surgeon, and there's pretty much never anything that can't be resolved. Cool. So what else have I got here? Trish, am I doing okay? Oh, I got some new stuff here. Wow, Steph, what's the most jaw-dropping case? Oh goodness, what have I had? I've had a patient who's had there's a bug called Mycobacterium. So it's the same thing that causes, it's a same family that causes tuberculosis. I've had a patient who had liposuction in an overseas destination. I won't say too much, but who had liposuction and a breast augmentation. Both of them got infected with a mycobacterium, which lives in dirt, and basically had stuff coming out of them for about 2 years. Was in intensive care for a while. Had to have hundreds of thousands of dollars worth of care in order to try to in the public hospital to try and fix, just to save her really. Ended up okay, and we had to do a whole lot of sort of fat grafting and other things to try and fix that. I've had patients with their eyelids kind of stuck down like this. I've had whole lots of stuff. So it's can be very difficult. Oh, thank you, Trish. Amazing. I'm liking that. Thank you. Thank you, Tracy. Appreciate it. Cool. Claire wants to know cost of a mummy makeover. Not being coy, Claire, I have no idea. As most of the people who've dealt with me will tell you, my job in the practice is I deal with patients. I look after the patients, and I have my staff look after the finances. But I would have thought it's probably going to be somewhere between $15,000 and $20,000, probably around about. Depends on a lot on health funds, all sorts of things. So somewhere between 10 and 20,000, I would have thought. But the easiest thing, Claire, my staff, just get on my website, email my staff. We get those emails 10 times a day. You can even send photos along if you want to. I can have a quick peek, and the girls will be able to give you a pretty accurate quote actually, and let you know, and also give any details of any health funds you may have, those sorts of things as well. So I'm sorry I can't be more specific. Jean wants to know about after brachioplasty, when would you be able to do 5 to 10 kilometer walks or do other gym exercises? Really quickly, actually, brachioplasty, pretty much you could be walking the next day and just building back up to those walks. There's no problem with that when it comes to brachioplasty. You're probably going to need to take it a little easy with arm exercises for maybe a month or so. It does also depend on your recovery. Brachioplasty and medial thigh reductions are the two operations that have probably some of the highest sort of like minor complications that are annoying. There's quite a high risk of a lymphocyte, of collections of lymphatic fluid in the area. And that's why one of the techniques we use to decrease that significantly is that if you're going to do a thigh reduction or an arm reduction, what you'll actually do is the area you're going to cut out of the skin, you actually liposuck it all first. Now that seems stupid. You're going to cut it out anyway. What are you doing liposuction for? Well, the reason is that by liposucking it, you are able to get the fat out from in between things while leaving the little network of lymphatics and blood vessels and things like that. And so that has been a game changer from the point of view decreasing fluid collections and things like that. If that happens, and it does happen, not that infrequently, then often you'll need to stick some needles and things in it and just sort of suck it out every few days until it goes away. On the rare occasion, probably 2 or 3 times in my career, I've had to go back and actually do something with that. Okay, so BBL, Brazilian butt lifts. Tina, thank you. My staff are brilliant. You're right. I love my staff to death. The Brazilian butt lift. The answer is I do it to some degree. You may be very aware of the fact that Brazilian butt lift has the highest risk of death of any cosmetic procedure in history. And it's all got to do a lot with technique. And I think the numbers in the US are something like 1 in 2,000 or 1 in 3,000 or something crazy. So there was but then a lot of that is very technique driven. Now, 2 of my very best friends in the US are probably some of the, most highly regarded BBL surgeons in the world, and the guys who actually developed the technique. And I think if you use their technique, you're safe enough. So the answer is I do it. Need to be selective about who we're doing it in and how we're doing it and what volumes we're trying to get into. But so I think that's an operation to be very careful and circumspect about, and be very careful who you choose to do it. Kelly, and no problems, contact details. Look, if you've got a pen, our phone number is 0755974100. Or just as easily, if you get on to, you just search the Layt Clinic, Layt Clinic, online. Our inquiries is our inquiry tabs there, and you could easily send something through to the staff, and they will be back to you tomorrow. If you were to send that tonight, you'll get a reply first thing tomorrow morning. That's probably the easiest way to do things, if you wish. Thanks, Trish. Cool. I've got some. I got a couple of other questions here. What do I use on scars? And do you use the same for stomach and breast? We tend to use seal tape. A lot of the silicon, most of the silicon-based tapes and things are good. Some patients, for things on faces and other areas where tape's not so good, we use a silicon application of a cream. But the best thing will be a seal tape or equivalent. That's what we use. The other thing we do routinely is we use LED for post-surgical scar improvement. And that's one of the few things that's really got good scientific basis. One of the things that another question someone asked me was about using Fraxel, and that it was really painful. I think the fractional lasers and things are probably better in scars that are established that you're trying to improve rather than early on. I think early on, probably the LED, which isn't painful at all, is of more use. Certainly in the burns units, for example, they'll use they'll put seal tape on, like we're talking about, silicon sheeting, and then if you get an established scar that's thickening up, we'll use often a CO2 fractional laser, but they are quite painful. Another couple of questions I've had. Oh yes, this is a really common question, so it's very much worth, I think, answering, and that's how long do breast implants last? Now, there's no such thing as a lifetime device. The most common reason I'll reoperate on a breast augmentation will be usually a tissue problem, not an implant problem. So normally it will be, we do the breast augmentation, someone has 3 or 4 kids, then the breast sags over it, we have to do a lift at the same time. If it's 10 years down the track, then I'll change the implant over usually, because that's a sensible thing to do. If, however, we have the problem we've got is that in the US, they had a moratorium on silicone breast implants back in the late 90s and early 2000s. That meant they had to use saline implants. Now, saline implants pretty much routinely go down at about 10 years. And so that really developed this idea that you need to change the implants at 10 years. Now, that's not the case. Now, I've done about 8,000 breast implant augmentation procedures over the last 20 years. Now, if I'm having to replace all of those at 10 years, that's all I'm going to do. And it's just not the case. Certainly there is a rupture rate, and they shouldn't be considered to be lifetime devices, because every time you move, if you've got one in, you're folding it and folding it and folding it and folding it. They're probably the most researched device in history, and they're very, very well manufactured, but they do fail, like anything. But it's not like changing the oil on your car or having to where you go, okay, you've got to change the oil every year. It's not like that. If there's a problem, you deal with it. And the other great thing is the safety things built into the modern breast implant is that the gel is quite thick. So if you get a rupture, then it doesn't tend to go into the tissues or do anything. It's just there. And so the commonest time I will see a rupture will be a patient where it's actually got no symptoms, they've got nothing going on. It's just picked up routinely when they're having an ultrasound scan as part of a mammogram and ultrasound. If that's the case, we'll normally go and just change the implant over. I hope that answers the question. You love LED. Good on you, Trish. Thanks. Awesome. Thanks very much, everybody. I'll see if I got another question here while my voice keeps going. Um, there's a question: can I have a tummy tuck with lipo and get the fat transferred to my breast without implants? Look, the answer is technically you can. The issue is one of reliability. Um, if you think about it, the average breast implant that I've put into my practice is 345 mils. Now, that would mean that if we take the average amount of take from a fat graft, that would mean we'd need to put in, which is about 50%, that would mean we would need to put in 700 mils of fat graft into each breast. That's really not practical. So what that then means is that you're going to have multiple procedures to put the fat in. You will not get an augmentation result. Now, often a better thing to do is to do what we call a composite breast augmentation, where you'll use a silicone gel implant, but you can use fat around it in order to cover it up.